Hi, I'm Dr. Joya Griffin, a veterinary dermatologist, and I'm here to talk to you about dermatologic conundrums. Dermatologic conundrums are cases that are often complicated that don't respond to typical therapy. I'm going to go through a series of fungal diseases that will often require special treatments and special expertise. So these are cases that you may want to phone your friendly neighborhood dermatologist for help with. So case 1, this is Buttercup. He was a 9-year-old male castrated domestic shorthair who was indoor and outdoor. He had presented to me with a non-healing wound on his right forepaw that showed a visibly pigmented lesion when you looked at it over the dorsal surface of the paw. Fine needle aspirate was performed of the lesion on Buttercup's paw. The cytology showed a pigmented fungal elements and a background of red blood cells and inflammatory cells. The lesion was consistent with a phaeohyphomycosis. These infections are caused by brown pigmented fungi that are found in the soil, and they typically inoculate wounds. With Buttercup being an indoor-outdoor cat, it's likely that some sort of trauma, even a cat fight wound, could have caused inoculation of the tissues with this fungus. So treatment is typically done by removing the lesion and excising the tissue completely. Because the lesion was on the distal paw, complete removal would require amputation of the limb. In some cases, antifungal treatment can be helpful, but you want to excise all of the visible lesion and disease first. So Buttercup was taken to surgery, and the wound was clipped and cleaned aseptically, and the mass was removed from the tissue. As you can see in the pictures, the fungus was actually diving between the tendons, and the surgeon had to carefully excise between the tendons to ensure that he didn't damage the tendons of the paw. The tissue was submitted for histopathology to confirm that this was indeed a phaeohyphomycosis. This photo here shows Buttercup 1 month after surgery and beginning treatment with terbinafine based on the fungal culture. He did very well for many months. However, about a year after the initial presenting to our clinic, he was seen to have some regrowth of the fungal elements underneath the tissue. Because at this point, Buttercup had already went through a very aggressive surgery, the owners elected to amputate the limb in order to remove all of the disease. Despite the amputation, Buttercup actually thrived as a 3-legged cat and did very well now that the lesions were completely gone. The second case we're going to discuss is Paraj, a 6-year-old female spayed domestic shorthair. This cat presented with a 4-month history of non-healing wounds. She was indoor mostly, but did go out on a porch, but was always observed by her pet parents. There was one other cat at home, but they were described to have a very friendly relationship and no known fighting had occurred. There was no prior history of skin disease with Paraj, and this was the only onset of lesions that she had ever had before. She had been treated with a couple different antibiotics, including marbofloxacin, and blood work 2 months prior to her initial presentation to me was within normal limits. The owners did feel like this lesion was probably due to a cat bite wound, but when asking them further, there was no real history of malice or aggression between the two cats. Initial cytology revealed pyogranulomatous inflammation with cocci that were intracellular and free. My differential list included deep resistant infection, potentially a mycobacterial infection, and immune-mediated disease, such as a sterile nodular dermatitis or paniculitis. This is Paraj. She's presented to me with a onesie on that was covering wounds that had been bandaged. Upon removing these bandages, I found multifocal deep ulcerations within the skin. And I guess it could appear that these were bite wounds, but they weren't really symmetric and they were multifocal. She also had a lesion on her chin and in the medial canthus below her right eye. Culture was initially performed and we started treatment with doxycycline and pentoxifylline. Pentoxifylline is an anti-inflammatory that also has wound healing properties. I chose this in the event that this actually was a non-healing wound to help improve blood flow and to help this wound heal faster. Pentoxifylline is a rheologic agent, meaning that it changes the shape of red blood cells, allowing them to fit through small vasculature so that you can feed the tissue and help to decrease inflammation and improve wound healing. The culture did come back consistent with the methicillin-resistant Staph aureus. Staph aureus is fairly common in cats, and so this does not necessarily indicate exposure from a human that carried methicillin-resistant Staph aureus. This can be a normal inhabitant of cat skin. We chose clindamycin based off of that culture and started her on that therapy. 1 month later, however, there was no improvement and the lesions had actually worsened. She had a mild fever and was lethargic and had not been eating well. So at that point, the family had elected biopsy and we submitted samples for histopathology. In the interim of receiving my results, I started her on cyclosporin and a tapering course of a steroid called triamcinolone. We continue with the clindamycin because of the previous diagnosis with the methicillin-resistant Staph aureus. Histopathology results were consistent with blastomycoses. This is a fungal infection that commonly affects the lungs and rarely affects the skin. This was the first case that I've seen of a cat with this disease. And in fact, it is reported that cats with deep ulcers can have blastomycoses, but in this part of the country, it was fairly rare to see this. Abdominal ultrasound was performed to rule out internal disease, and chest radiographs were also done. The chest radiographs revealed no significant findings, and her CBC and chemistry panel was also negative, or within normal limits. I was worried that there could be disseminated disease and that the skin lesions that she had that were infected with blastomycoses might have represented expansion from somewhere internally, but the internal medicine doctor did not see that. So at this point, we elected to stop the cyclosporin and started a medication called itraconazole, which is commonly used to treat blastomycoses in dogs and cats. 2 weeks after biopsy, her forelimb became edematous and she was developing a poorer appetite. On clinical exam, I noted edema of the left foreleg, soft tissue swelling in her axilla, and numerous draining tracts on her thorax, flank, with crust on her ventral chin and erosions ventral to her right eye. The lesions had expanded and she was doing very poorly. Blood work at that time showed a severe anemia of 11%. I discussed with the owners the severity of her condition at this point and recommended hospitalization with possible transfusion, but due to the expansion of the disease and the multifocal nature, there likely was nothing that was going to do to help save Parage. The owners elected euthanasia, unfortunately. Blastomycosis is often a devastating disease. It's most commonly diagnosed in dogs that have exposure to the outdoors and is very common in the Mississippi, Ohio, and Tennessee River basins. This is a broad-budded yeast with a large encapsulated halo, and it can be seen on cytology and is usually numerous in tissue when biopsied. Typical presentations are dogs that present with weight loss, lethargy, they have decreased activity, and there's sometimes dogs that have no lesions on their skin whatsoever. They can present with coughing and other symptoms of systemic disease. It's often treated with itraconazole and sometimes steroids, as the treatment for the disease will cause a die-off of the fungal elements, which causes lots of inflammation in the tissue. So steroids are given in conjunction with the antifungal to prevent that inflammatory response. Unfortunately, in Parage's case, biopsy was not performed at the initial presentation due to financial constraints. Had biopsy been performed, we may have been able to diagnose her sooner and provide her the care that she needed. Blastomycosis should be added to your differential list for cats that present with non-healing wounds and large abscesses, especially in endemic areas like ours. The third case we're going to discuss is NASA, an 8-month-old male intact German Shepherd. He presented to me with a 3-month history of non-healing wounds. He had been treated with cefpodoxime based on previous culture with no improvement. A urine blastoantigen test had been performed and was negative, and his litter mate was unaffected. And we'd actually found that NASA had traveled somewhere out west because of his Instagram photos, which he actually had his own Instagram page, and it showed that he was swimming in some sort of water. NASA presented to me with multifocal wounds. He had been chewing at his right hind leg, at the distal tarsal area, and at his tail base. He had multifocal draining tracts with dry crust around the dorsal base of the tail and erosive dermatitis on his distal right hind limb. This started from the level of his tarsi and extended distally over the dorsal part of the paw. He also had erosive patches on his right thorax and shoulder region and on his right hip. Cytology was performed, and at that time, nuclear streaming and rare rods and cocci were found. Because of the extent of these lesions and the multifocal nature, biopsy was performed. I also submitted a fungal culture and PCR to rule out a severe case of dermatophytosis. On my differential list, of course, included fungal disease, either deep or superficial, Pythium, mycobacterial infection, or a form of autoimmune disease such as cutaneous vasculitis or cutaneous lupus, erythema multiforme, or neoplasia. I initially started treatment with ketoconazole because of my concern for a deep fungal infection. Biopsy results were consistent with either a mucorales or a Pythium, though my pathologist felt that Pythium was less likely. I did submit a fungal PCR to try to confirm what our diagnoses was. In the interim, we started itraconazole and terbinafine and stopped the ketoconazole because of the susceptibility patterns of mucorales. He was also started on hyperbaric oxygen therapy at our local internal medicine specialist. Fungal PCR was negative for Pythium and actually revealed a fusarium, which sort of didn't make sense to me because this is a type of fungus that grows in the soil and typically doesn't cause infection. The owner had called reporting worsening of the lesions, and so we added on minocycline because I was still worried about Pythium with how aggressive the lesions were. I discussed experimental treatment with him as well, and we decided to start him on immunotherapy, which was formulated for us by a fungal laboratory. CBC and chemistry panel and ultrasound were performed to rule out internal disease because of the worsening of the cutaneous lesions that he had. Once the immunotherapy was initiated, he began the treatments every 5 days and was about 1 month into treatment when he came back in for a recheck exam. Despite initial antifungal therapy, NASA continued to chew on his leg. The owner would not keep an e-collar on him, and he would constantly gnaw and chew at his foot. So I restarted him on minocycline for secondary infection, along with steroid to help to reduce the inflammation. He was also started on gabapentin for pain. Due to the worsening of the lesions, the owner elected amputation and radical excision of all of the lesions. Initial improvement was seen after the amputation and radical excisions of any gross visible disease. He had increased energy and appetite and had gained a little bit of weight. I had the tissue resubmitted for pathology, and it was more consistent with Pythium. Initially, NASA did very well. His dad actually stopped the minocycline, but then he developed draining tracts, so we started applying mupirocin to those lesions. He had tapered the prednisone, and after doing that, along with stopping his antifungal, NASA's appetite started to decrease. He was rapidly losing weight and had new lesions. Upon examination, he had draining tracts at the incision lines, and on cytology, I found pyogranulomatous inflammation. We decided to restart him on minocycline, along with the antifungal terbinafine, and we're going to continue with the Pythium vaccine. We discussed further therapy by increasing the steroid to help with inflammation, and some experimental therapy was also discussed. We discussed adding on mefenoxam liquid, which is actually a plant fungicide, but there have been small reports that this can help kill Pythium, and also discussed an adjuvant vaccine that's used in ponies in which Pythium is endemic in their herds, and this could have been formulated for us by the fungal laboratory that prepared his immunotherapy. The owner actually elected euthanasia due to his decline. Pythium is an aquatic oomycete. It's fungal-like but does not contain a cell wall. It's been referred to as swamp cancer and is associated with ingesting or standing in stagnant water or through wound inoculation. In NASA's case, this was likely contracted from travel and potentially from swimming in water. However, his owner did live in Indiana, and it has been seen as far north as southern Indiana, but it is endemic in states that border the Gulf of Mexico. It's often associated with GI disease, weight loss, vomiting, and diarrhea, and ultimately can be associated with death. Lesions commonly occur on the face, tail, and limbs, and can resemble acrolick lesions, which can make this diagnosis very confusing and difficult. Treatment is best through amputation, but in NASA's case, the lesions were multifocal and very difficult to remove all of the lesions. We did give him the best chance that we could through the treatments that we did, including some of the more experimental treatments with immunotherapy. In humans, Pythium is associated with internal disease and patients who are receiving chemotherapy or other immunosuppressive medications. It can quickly go vascular and into the lymphatics, which makes it spread to other parts of the body. It's a devastating disease. This is the first case of Pythium that I've recognized in my career in this part of the country, living in the Kentucky area. I'm concerned that through global warming and climate change, that diseases like this and other deep fungal infections are coming north, and that they need to be on our differential list for cases with deep, non-healing wounds. Dermatologic conundrums can involve immune-mediated diseases and internal diseases that manifest in the skin. This case is about Nico. He's an 8-year-old male castrated German Shepherd. He presented to me with a 1-year history of crusting that started on the nose. He had been initially treated by his family veterinarian with doxycycline and niacinamide, and tacrolimus was applied to the lesions. He then was transitioned to starting a tapering course of prednisone and was biopsied 1 month prior to presenting to me. His biopsy was fairly nonspecific. It showed lymphoplasmacytic and eosinophilic dermatitis with dermal edema and fibrosis, and there was some pigmentary incontinence. The pathologist did not come down on a single diagnosis. Upon presentation to me, cytology was performed along with a culture, and the blood work was submitted at the family veterinarian to include a CBC, chemistry panel, and a thyroid panel. This family was very conservative with their finances, and so we had to do things in kind of a stepwise fashion, which is real world. We tried to do the best that we could to provide the best care we could. Upon presentation, Nico had crusting on the bridge of the nose, on his right carpi, on the pinnae, with erosions on the medial aspect of the pinnae. He had erosions on his ventrum and medial thighs and in the perianal area. He had a large amount of purulent debris within the ear canals, and he smelled terribly. This is a dog that you smell before you enter the room. On cytology, he had tons of bacteria, as well as nuclear streaming and neutrophils, eosinophils, and macrophages. He was initially started on pentoxyphylline, and I increased the prednisone that was started by the family veterinarian while we were waiting for our culture results. Culture that was performed was consistent with a non-resistant staph and a streptococcus. The blood work that was performed at the family veterinarian was consistent with hypothyroidism, and he was started on thyroxine supplement. A biopsy was performed due to worsening of his lesions. The histopathology results showed cytotoxic dermatitis with mural folliculitis. This is inflammation that's within the follicles, and it's consistent with erythema multiforme, a form of autoimmune disease. In other areas, oddly, he had subcorneal pustules and acantholytic cells, which you can see with pemphigus. So he had 2 different features of 2 different types of autoimmune disease, both of which are difficult to treat. And so we thought maybe this all could be lumped together and be due to a drug reaction. Initial treatment was done with prednisone, mycophenolate, and antibiotics. Unfortunately, due to financial constraints, cyclosporin or other immunosuppressive medications that required more frequent blood work monitoring was not possible. Initially, crusting improved, but the erosions persisted. We stopped the mycophenolate and switched over to azathioprine. Unfortunately, Nico seemed to worsen off of the mycophenolate, so this was restarted along with doxycycline. Ultimately, 1 year out from initial presentation, Nico is stable on mycophenolate and doxycycline. He is steroid dependent, but we're working on tapering the steroid to an alternate day dosing. He is a bit overweight from the steroids that he receives, but we're working on weight loss as well. The next case we're going to discuss is Mordecai, a rainbow chameleon. He was of unknown age because the parent that brought him in wasn't the original owner, but he had a 2 to 3 year history of lesions on his dorsum that were presumed to be scars from previous burn injury, and he had an abnormal shedding pattern. Upon presentation, Mordecai did have an abnormal shedding pattern. He also had these multifocal pinpoint crusted lesions, and he had previous scarring with depigmentation over the dorsal spine. Initial workup for Mordecai included cytology and culture for yellow fungus. Differentials for Mordecai included bacterial infection, subcutaneous nematode or filaride infection, yellow fungus, cutaneous vasculitis, or other immune-mediated diseases. I started him on an antibiotic pending the culture results. However, the culture for yellow fungus was negative. 1 month later, after treatment with antibiotics, there was no improvement, so biopsy was elected. Histopathology was consistent with papillomatous plaques, secondary to papillomavirus. This disease is usually transmitted by the owner from infected lizards by sharing housing, bowls, or water. There's no specific treatment for papillomavirus. However, Mordecai died unexpectedly within weeks after initial presentation. Necropsy was performed, and it was consistent with multi-organ failure, sepsis, and pulmonary hemorrhage. So unfortunately, Mordecai died of something else unrelated to his skin disease. The next case we're going to delve into is Penny. She's an 11-year-old female spayed Yorkie with a 1-year history of nasal depigmentation. She had a 2 to 3 month history of scaling that had occurred on her skin that was most prominent over the dorsum. She had had no previous response to enrofloxacin that was prescribed by the family veterinarian. 2 months prior to presentation, CBC and chemistry panel that were performed were within normal limits. Penny presented with lesions that consisted of scaling along her dorsum with multifocal crusts. She also had depigmentation of her nasal planum that left behind kind of a grayish, smooth appearance to the nose because she had lost the normal cobblestone architecture of the nose. She had depigmentation of the lip margins as well as the areas around her eyes. Biopsy was performed at initial presentation, and this was consistent with epitheliotropic T-cell lymphoma. I sent her to internal medicine for full staging. 3 view chest radiographs were performed along with abdominal ultrasound, and all were found to be within normal limits. The internal medicine specialist discussed with her a treatment with lomustine or a full CHOP protocol or even treatment with Loverdia. The owner elected to treat with prednisone and lomustine and a treatment of safflower oil. The next case I'm going to discuss is Tucker. He's the cutest little male castrated Frenchie, and he was approximately 1.5 years of age. Mom had recently moved from the Pacific Northwest to the Evansville area. He had a 1-year history of non-seasonal pruritus and had actually seen a veterinary dermatologist in the Portland area. He had also been treated with several anti-itch medications, including oclacitinib and lokivetmab, and had worsened when he had moved from the Pacific Northwest to Evansville. At this point, Tucker was steroid dependent. Upon presentation to me, he had widespread infection. There were lesions of alopecia, moist erosive skin in his inguinal area, on his paws, and interdigitally, and he also had very malodorous and scaly skin. Initially, we treated the infection that he had with antibiotics and started him on a protocol of cyclosporin and ketoconazole. I combined ketoconazole with the cyclosporin to help lower the dose. Ketoconazole is able to reduce the dose that you give of cyclosporin because it inhibits the P450 enzyme system and actually allows you to receive a higher amount of cyclosporin in the body. I also started him on a tapering course of triamcinolone because cyclosporin takes 3 to 4 weeks to take full effect. 2 months into treatment, he was doing well. His itch was improving and his infections were resolving. Then he presented to me 3 months after his initial presentation with a 1-month history of new plaque-like lesions all over his skin. Tucker presented with multifocal crusted papules. These were all over his face, and he had erythematous papules on his chest, ventrum, and in his axillary region. Owner reported that 2 months ago, he was switched from name brand cyclosporin to a generic modified cyclosporin, and he started to develop these lesions all over his skin. His itching, however, was improved, but he didn't look so good. He was diagnosed with psoriasiform lichenoid dermatitis, and this was secondary to the cyclosporin switch. So our plan was to switch him back to the name brand and to treat the secondary infection that he had. Psoriasiform lichenoid dermatitis is a very rare occurrence that can happen with cyclosporin. And it's actually not very common, but in this case, there was a clear difference between the name brand and the generic for this patient. Another common thing that can occur with cyclosporin is gingival hyperplasia, so it's always important to look into the mouth of patients receiving this medication. If gingival hyperplasia is noted and it's mild, you may not need to do anything, but if it's more severe, you can try reducing the dose to help resolve that inflammation in the tissue. If that's not possible, there have been studies with using azithromycin or azithromycin toothpaste to help reduce the inflammation and the swelling along the gingiva. And here's Tucker, 1 month back on the name brand cyclosporin, doing well, itch is resolved, and his infections are stable. These cases represent rare and unusual dermatologic conditions. They often require advanced diagnostics and histopathology to achieve the diagnosis. Treatment can be difficult, and referral to a veterinary dermatologist may be necessary. If you have any questions or would like to learn more, find me on Instagram or check out my website at drjoyadvm.com. Thanks so much for watching.